Hey everyone, welcome to the deep dive.
Yeah, welcome. We're really excited to be here today.
So we're going to be your guides through the world of the MCCQE exam.
We're Harvey and Donna, and we both know this exam can be tough.
Yeah, for sure. We've been there and we're here to make it a little bit easier for all you Canadian medical students out there.
Exactly. We're going to break down all those big concepts that you'll need to know using some reliable sources like stat pearls.
Of course, before we get started, just a quick disclaimer. This is all just for informational purposes and definitely not medical advice.
Right. Always talk to a real healthcare professional for any medical concerns.
Okay, now let's jump into it. Today we're tackling some respiratory conditions that you'll definitely want to know for the exam and for your future practice.
Yeah, these are conditions you'll see a lot. Acute respiratory distress syndrome, ARDS, pleural effusion, and pneumothorax.
They can be tricky,
Oh,
but once you understand what's going on, they're not so bad.
right. And that's what we're here for,
Yeah.
to break it all down.
All right, let's start with the ARDS. So picture this. You've got a patient who's struggling to breathe. Their x-ray shows fluid in their lungs, but their heart is fine. What comes to mind?
That's a pretty classic presentation of ARDS. It's a syndrome, meaning it's a group of symptoms caused by a bunch of different things.
So how do we even start to diagnose ARDS? What are the key things we need to look for?
You're looking for a few things. First, severe hypoxemia, which means low blood oxygen levels. Then you'll see bilateral lung infiltrates on the x-ray. And then there's a really important ratio that helps us see how severe it is, the PaO2 FiO2 ratio.
Okay, can you break down that ratio for me? What does it mean and why is it so important in ARDS?
Basically, it tells us how well your lungs are transferring oxygen from the air into your blood. In ARDS, the lungs are damaged, so this transfer isn't happening efficiently.
So a low ratio means the lungs are in trouble.
Mm.
But what causes this damage in the first place?
That's where a good patient history comes in. It could be sepsis, pneumonia, trauma aspiration, even inhaling something toxic. Lots of possibilities.
Wow, so many different causes can lead to the same problem, this inflammation in the lungs.
Exactly. And this inflammation makes the tiny air sacs in the lungs leaky, so fluid builds up and oxygen can't get through.
I can imagine how scary that would be for the patient. So what's the first thing we do? How do we help someone with ARDS?
The most important thing is supportive care. And that usually means mechanical ventilation. But we have to be super careful not to make things worse. That's where lung protective ventilation comes in.
Lung protective ventilation. Sounds a bit counterintuitive, like we're helping the lungs but also trying not to hurt them further.
Exactly. It's a delicate balance. We need to give the lungs enough support to do their job without causing more damage.
What are some of the things we need to watch out for when we're doing this balancing act?
There are three main things to keep in mind: volutrauma, barotrauma, and electrauma.
Whoa, those are some intense sounding traumas. What's the difference between them?
Well, volutrauma happens when we use too much air with each breath. Like overinflating a balloon, you can actually stretch and damage the lung tissue.
Oh, I see. So we need to keep the volume of air low. What about barotrauma?
Barotrauma is all about pressure. It's like squeezing that balloon too hard. You can cause ruptures and leaks in the lung.
Okay, so we need to keep the pressure under control as well. And what was that third one? Atelectrauma.
Right. Atelectrauma is when the tiny air sacs in the lungs collapse. We prevent this by using something called PEEP, positive end expiratory pressure.
PEEP. Okay, I think I've heard of that. But how does it actually work?
Think of it like blowing air into a floppy plastic bag. It's hard to keep it inflated right, but if you keep a little bit of pressure in the bag, it stays open. That's what PEEP does. It keeps those air sacs from collapsing, which helps the patient breathe.
So PEEP is like that little bit of extra help that keeps everything open and working properly.
Exactly. And it can actually reduce the amount of oxygen we need to give the patient.
That's amazing.
Yeah.
It's fascinating how much thought goes into managing ARDS.
It definitely takes a lot of careful monitoring and adjustment.
Okay, so let's move on to another condition that involves fluid buildup in the lungs. Pleural effusion. When you hear fluid around the lungs, what comes to mind?
Most people immediately think of heart failure. And while that's definitely a common cause, it's not the only one.
Right, there's more to it than just fluid buildup.
Exactly. The pleural space is the area between the lung and the chest wall. It normally has a thin layer of fluid so the lung can move smoothly. But when that fluid starts building up, it can compress the lung and cause breathing problems.
So it's not just the presence of fluid, but the amount of fluid that's important.
Exactly. And this is where we get into the different types of pleural effusion, transudative and exudative.
Okay, those terms always sounded a bit intimidating back in med school. What's the difference?
Think of transudative effusion like a leaky pipe in your basement. It's caused by pressure imbalances, like in heart failure, where fluid is forced out of the blood vessels and into the pleural space.
Okay, so transudative is all about pressure. What about exudative?
Exudative effusion is more like an inflammatory response. Like when you get a cut on your finger, it gets red swollen and oozes fluid, right? That's because of inflammation.
Ah, so exudative effusion is caused by inflammation or infection in the lung itself.
Exactly. And this leads to a buildup of protein-rich fluid in the pleural space.
Okay, so transudative is like a leaky pipe and exudative is like a cut. That's a good way to remember it. But how do we actually tell the difference in a real patient?
That's where Light's criteria comes in. It's a set of lab tests that looks at the protein and LDH levels in the pleural fluid compared to the blood.
Light's criteria. Okay, I remember that name, but how does it actually work?
It basically helps us determine if the fluid buildup is due to pressure problems, like in heart failure, or if it's from inflammation or infection.
So we need both the clinical presentation and the lab results to get the whole picture. What about the patient, though? What are they experiencing when they have a pleural effusion?
It depends on how much fluid is compressing the lung. Some patients don't have any symptoms at all, while others have shortness of breath, chest pain, or cough.
So those symptoms alone aren't enough. We need that fluid analysis to really know what's going on.
Absolutely. And sometimes we need to do a procedure called thoracentesis.
Thoracentesis.
Yeah.
That's where we actually draw fluid out of the pleural space, right?
That's right. It helps us diagnose and treat the effusion. We can analyze the fluid and look for infections or even cancer cells. Plus, we can relieve the pressure on the lung and make it easier for the patient to breathe.
So it's a 2-for-1. We get information and we help the patient at the same time.
Exactly. But like any procedure, there are risks. We always have to be careful about things like bleeding infection and even pneumothorax if we accidentally puncture the lung.
Okay, so it's a valuable tool, but we need to use it carefully.
Exactly.
Okay, let's switch gears one last time for this part of our deep dive. Imagine you're in the ER and a young, healthy person comes in with sudden sharp chest pain and difficulty breathing. The X-ray shows a collapsed lung. What's the first thing you think of?
That definitely sounds like a pneumothorax. Air gets trapped in the pleural space and puts pressure on the lung, causing it to collapse.
Okay, so air where it shouldn't be and a lung that can't do its job properly. Not a good combination. But are there different types of pneumothorax?
Yeah, there are actually 4 main types: primary spontaneous, secondary spontaneous traumatic, intention.
Can you break this down for me? What's the difference between primary and secondary spontaneous pneumothorax?
Primary spontaneous pneumothorax is more common in young, healthy people. Sometimes they're tall and thin, or they might have a history of smoking.
So it just kind of happens out of the blue?
Yeah, we think it's caused by weak spots on the surface of the lung that rupture and leak air into the pleural space.
Okay, so a tiny leak that throws everything off. What about secondary spontaneous pneumothorax?
That happens in people with existing lung diseases like COPD or cystic fibrosis. The lung tissue is already damaged, so it's more likely to rupture.
So it's like adding insult to injury.
Yeah, pretty much.
What about traumatic pneumothorax? That one seems a bit more straightforward.
It is. It's usually caused by an injury to the chest, like a rib fracture that punctures the lung or a wound that lets air in.
So lots of ways for air to get where it shouldn't be. And what about that last type you mentioned? Tension pneumothorax.
That one's the most serious. It can happen with any of the other types if the air can't escape from the pleural space. It's like a one-way valve. Air gets in, but it can't get out, so the pressure builds up and starts compressing the lung and even the heart and blood vessels.
Oh, wow. That sounds really dangerous. What are the signs of a tension pneumothorax? What should we be looking for?
You'll see severe shortness of breath, chest pain, a rapid heart rate, and low blood pressure. And you might even see the trachea, that's the windpipe, pushed to the opposite side.
Okay, so we're looking for respiratory distress plus that tracheal deviation, which is a red flag.
Exactly. It's a life-threatening situation that needs immediate attention.
So what do we do? How do we treat a tension pneumothorax?
The fastest way to relieve the pressure is with needle decompression. We insert a large needle into the pleural space to let the air out.
Okay, so it's a quick procedure to stabilize the patient. What happens after that?
Usually we'll put in a chest tube to continuously drain any air and fluid. That way the lung can re-expand and we can prevent the pneumothorax from happening again.
So needle decompression is like the first aid, and the chest tube is the long-term solution.
You got it.
Phew, we've covered a lot of ground today. ARDS, pleural effusion, pneumothorax. It's a lot to take in, but hopefully it's starting to make more sense.
Definitely. And remember, we're just scratching the surface here. We'll go into more detail in the next parts of our deep dive.
So stay tuned, everyone. There's much more to come. All right, welcome back to the deep dive.
Yeah.
We're going to keep exploring these respiratory conditions that we know can be tricky on the MCCQE.
Yeah, and remember, it's not just about memorizing facts. It's about really understanding how these conditions work.
Exactly. So let's get back to ARDS. We talked about lung protective ventilation being so important, but how does that actually play out when we're treating a patient?
Well, imagine trying to inflate a really fragile balloon. You put in too much air, it pops. Too little, and it won't inflate properly. Lung protective ventilation is all about finding that perfect balance, giving the lungs enough support without causing more harm.
Okay, so it's a delicate process. What are some of the key things we're monitoring and adjusting?
So first, we have those low tidal volumes. Remember, we want to avoid overinflating those delicate air sacs. We're aiming for about 6 to 8 milliliters per kilogram of ideal body weight.
So we're being really gentle with the amount of air we're giving. And what about the pressure? You mentioned barotrauma earlier.
Right. We need to keep that plateau pressure below 30 centimeters of water. That helps prevent high pressures from damaging the lung tissue.
Got it. So low tidal volumes, controlled pressure, and then there's PEEP. Can you remind me how that fits into this whole strategy?
PEEP is all about keeping those tiny air sacs open at the end of each breath. Think of it as a little splint that prevents them from collapsing.
Ah, okay. So PEEP is like that extra support that helps everything stay open and functioning.
Exactly, and it can actually reduce the amount of oxygen we need to give the patient.
Wow, that's incredible. It's amazing how much goes into managing a patient with ARDS.
It really is. It's a constant process of monitoring and adjusting.
Okay, let's go back to pleural effusion for a minute. We talked about thoracentesis being a really useful tool for diagnosis and treatment. Can you walk me through what actually happens during that procedure?
Imagine using a tiny camera to see inside the chest cavity. That's basically what we're doing with thoracentesis. We use ultrasound to find the exact location of the fluid, and then we insert a needle through the chest wall into the pleural space.
So we're using imaging to guide us every step of the way. What happens once we're in the pleural space?
We can do a couple of things. We can take a small sample of fluid to send to the lab, or we can actually drain a larger amount of fluid to relieve the pressure on the lung.
So we get information and we can help the patient feel better at the same time.
Exactly. But like any procedure, there are risks. We need to be careful about things like bleeding infection and even accidentally puncturing the lung.
Right, so it's not a procedure to be taken lightly.
Definitely.
All right, let's talk about pneumothorax again. We talked about tension pneumothorax being a really serious complication. Can you remind me how that develops and what makes it so dangerous?
So imagine a one-way valve that only lets air in but not out. That's what happens at a tension. Pneumothorax air gets trapped in the pleural space with each breath, and the pressure just keeps building up.
Okay, so it's like a pressure cooker in the chest.
Pretty much. And this pressure starts to squeeze the lung, and eventually it can even push on the heart and major blood vessels.
Oh, wow. So it affects more than just the lungs.
Exactly. That's why it's so dangerous.
Yeah.
We need to recognize the signs early.
What are those signs? What should we be looking for?
The patient will have severe shortness of breath, chest pain, a racing heart, and low blood pressure. You might even see the trachea, the windpipe, pushed to the opposite side.
So we're looking for those signs of respiratory distress, plus that tracheal deviation.
Exactly. And remember, tension pneumothorax can happen with any type of pneumothorax. So if a patient starts going downhill quickly, we need to think about this and act fast.
So what do we do in that situation?
We need to release the trapped air as quickly as possible. The best way to do that is with needle decompression. We put a large needle into the pleural space to let the air escape.
Okay, so it's a quick procedure to get things under control. What happens after that?
Usually we'll put in a chest tube to drain any remaining air or fluid. That way the lung can fully re-expand and the pneumothorax won't come back.
Okay, so needle decompression is like the emergency fix, and the chest tube is the long-term solution.
Exactly. That's a good way to think about it.
This has been a really helpful review of these conditions. We've talked about ARDS, pleural effusion, and pneumothorax. It's amazing how much there is to know about each one.
And remember, we're just scratching the surface. We'll go into even more detail in the next part of our deep dive.
Yeah, so stay tuned, everyone. There's still more to come. All right, welcome back to the deep dive for the final part of our journey into these respiratory conditions. We've covered a lot, but there's always more to learn.
Right. We've talked about the big picture of these conditions, but let's zoom in on some of those finer details that can really make a difference in diagnosis and management.
Okay, sounds good. Let's start by revisiting pneumothorax. We talked about tension pneumothorax being a real emergency, but what about those less dramatic presentations, the ones that might be a bit trickier to catch?
Yeah, those subtle cases can be tough. You might have a patient with a small pneumothorax and they're only having mild symptoms, maybe a little bit of chest pain or shortness of breath.
So it's not always a dramatic presentation.
Exactly, but that's where the physical exam is so important. We need to be looking for those subtle clues.
Like what kind of clues?
Well, you might hear decreased breath sounds on the affected side, or you might notice hyperresonance to percussion.
And of course, we can't forget about tracheal deviation.
Right, that's a big one. The trachea will shift away from the side with the pneumothorax as the pressure builds up.
Okay, so we're gathering information from the history, the physical exam, and of course, the chest x-ray.
Absolutely. And all of that helps us decide how to manage the pneumothorax.
Okay, now let's think about something else. We've been talking about these respiratory conditions one at a time. But in real life, things are often more complicated. Patients don't always present with just one problem.
You're absolutely right. We need to be thinking about comorbidities and how different conditions might interact with each other.
Like a patient with COPD might be more likely to develop a secondary spontaneous pneumothorax.
Exactly. Or someone with heart failure might have both pleural effusion and pulmonary edema.
It's like a puzzle with multiple pieces.
That's a great analogy. And that's why it's so important to have a deep understanding of how these conditions work.
We need to be able to see the connections and make informed decisions based on the whole picture.
Exactly. And that's what the MCCQE is all about. It's not just about memorizing facts. It's about applying your knowledge to real-life scenarios.
All right, so let's recap. We've covered ARDS, pleural effusion, and pneumothorax. We've talked about their causes, their symptoms, their diagnosis, and their management.
We've also talked about the importance of looking for those subtle signs, thinking about comorbidities, and always being prepared for the unexpected.
It's been a whirlwind tour of respiratory challenges, but I hope you're feeling more confident about tackling these topics on the MCCQE and in your future practice.
And remember, resources like Stat Pearls are a great way to keep learning and practicing these concepts.
Exactly. Keep studying, keep practicing, and keep that curiosity alive.
Yeah, the best doctors are the ones who never stop learning.
And on that note, I think we've reached the end of our deep dive.
Thanks for joining us, everyone.
We'll see you next time.